Welcome everybody to another Zoom call. Um, just want to point out, as I do always, to go to the member site for announcements, and there are several new announcements. And several changes on the Zoom call, or excuse me, on the member site. You have now a new lower fee for follow-up phone visits. It's $135 for 15 minutes now, and you can self-schedule. So right below that, right below this, what's new on the member site is this self-scheduling button. So you could just you fill out the request form, the info form, and you self-schedule. This goes right to my Calendly schedule, and you can pick a time that works for you, and you can schedule yourself. It makes it simple. So you're thinking about scheduling on the weekend, and oh, I got a call on Monday. You don't have to do that anymore. You can just schedule yourself. Remember that if you fill out a subscription for your supplements, there's a 5% discount on all the subscriptions. Um, And please remember to fill out the cheek swab request form. That's at the bottom of that's on the cheek swab page, and it's on the um uh uh members homepage. So please do that. We also, on our website, we have a schedule now page where you could schedule from the website too if you didn't go to the member site for some odd reason. If you're just looking on your phone and you don't have your password to the members, I don't. Just go to the website and you can schedule from the website too. Also, watch some of the new videos. I've been promising that I'm going to get videos done on lab interpretation, on standard lab interpretation, since most of you are getting a CBC and a complete metabolic panel and some other labs. I will have videos up on all standard lab interpretation, so it'll help you understand what you're getting, since often we're finding that you're getting very little interpretive value from the doctor who requested the labs. Talked to somebody the other day that they said that they were leaving the visit with the oncologist, and she had to say, well, what about my labs you had done? And he said, oh, he didn't even know that he had requested labs, or remember that he requested labs. Pulled him up and basically brushed them off with no interpretation whatsoever when she had some major things going on in those labs. If you have anemia, this is where we're finding common patterns. It's not uncommon for somebody with cancer to have anemia. If you have anemia and your doctor isn't requesting labs at least on a monthly basis, oftentimes it should be more appropriate to request them on a weekly or bi-monthly basis if the person has pretty severe anemia and they are not doing that to watch the anemia. That's just not good. That's borderline malpractice when they're not keeping an eye on that, because that can cause a lot of ill health, and just not a good thing to not keep an eye on. You need to be watching that. So make sure you're getting, your doctor, if you're using your doctor to request labs so that you can get it covered by insurance, make sure that you are requesting them frequent enough. Remember, labs, just like any other test, is a test. It's a static picture in time, and it's best to look at a more vibrant picture, which is going to look at those values over time. So you need subsequent lab testing in order to look at those values. Now, some things you don't need that when you're looking at antibodies or something like that, but typically when you're looking at a CBC and a complete metabolic panel, you need a picture over time. So you need subsequent tests and retests, therefore, to look at those lab values to really know how to see your progress, or the direction that things are going is so important. So watch the new videos in the lab section. I've also got blog posts on them as well. And soon, within the next few weeks, I'll have videos on just about every lab test that you could get. And I think it'll helpful for you to not only to understand them and to understand the interpretation of that, but also to understand the need for requesting those and to the need for running those. So, you know, it's often I hear from people that, well, why do I need to run those? The doctor said they're all normal. um, the one video that I created is an explanation of what the difference between normal lab values are and what your oncologist or your doctor might think is normal, and what functional lab values are or optimal lab values are. There's a distinct difference in that. We want to catch dis-ease before it becomes an emergency room visit. So watch that video. It's in the lab section. And it's on a number of the courses, and it's on our website in the blogs. So I know you have to listen to me, but stomach through it, put on a set of earmuffs and get a glass of bourbon and sit down and help interpret labs. For those that just jumped on, a reminder, you can now self-schedule all your follow-up calls right here. It's right on the main page of the member site. It's also on the schedule now page on the website. That's a new page on the website. Okay, reminder to look at the blogs. We're going to talk about some of those in these questions that were asked. First question that came in, I was wondering about using an electric blanket with the right machine bulb under the blanket. Is there a problem with doing that? I'm concerned about the wavelengths of the electricity running through the blanket. So there is not a problem with using an electric blanket or an electric heating pad with the right machine. It won't interrupt the frequencies. The dirty electricity or the EMFs that you might get from the electric heating pad or electric blanket are going to be far surpassed by the right frequency. So there's not a problem there. There's argument, though, whether there's health benefits that can, or health negative effects that can take place using an electric blanket. Now, there's people on one side of the spectrums that says that it's very bad for you because it's creating a different circuit that can affect your body's electric field, and using an electric blanket is not good for you. And then there's people on the way on the other side of the spectrum that says that's a bunch of fooey nonsense of a bunch of new age weirdos. I fall probably in the middle of that. I don't use an electric blanket, nor does my wife, because I just am concerned about the EMF production of the electric. We don't have electric blankets. I've never been able to test it with my EMF meter, but you know, there's concern there. The reason why I like our electric heating pads that we sell is because they use those tourmaline discs in them, so they're not producing EMFs like a regular coiled heating pad is. So you're getting some better wavelengths in that than you are getting from a coiled heating pad. But I understand that some people just have to use an electric blanket because they're freezing to death. They have, you know, you do want to investigate maybe why you would need to use an electric blanket. Do you have, we going over these in all these lab videos, but you know, what would be reasons why I'm cold all the time and I'm freezing? Is it because maybe I just keep my temperature down and my spouse likes the temperature down in the house and it's very cold? Well, extra blankets should work for that. Well, no, I don't care how many blankets I have, I'm still freezing. We need to assess thyroid function. So getting a complete thyroid panel. Most commonly, though, it would be low blood values as far as red blood cells go, and that is called anemia. So a CBC, complete blood count, would be the test to analyze that. If you haven't had blood work for a long time, consider getting our complete wellness panel if you don't have the ability to get insurance coverage through getting your doctor to order it, our complete wellness panel has CBC, complete metabolic panel, multiple other tests that are of great value, and a complete thorough thyroid evaluation in it. $132 plus whatever you have to pay for your blood draw. Pretty darn inexpensive. So consider getting that done. But no, it will not affect the rife frequencies. I unexpectedly needed a blood transfusion a few weeks ago when my hemoglobin levels were very, very low. So I have low hemoglobin levels. That's part of anemia. So 7.7 is very low, and I highly recommend that if a person has those kind of levels, that getting a blood transfusion is the right thing to do. I later called the blood bank to learn if I could have specific people donate blood for me, like family members, for future possible transfusions. My motivation in part was to have people who did not take the COVID vaccine donate to me directly. The blood bank makes it very difficult to have a donation directed specifically to you. The woman told me that the vaccine is not in the blood, but then said that they do not even test for this. My question is, do you think this is true? That the vaccine material, mRNA, DNA, do not circulate in the bloodstream and therefore are not a concern when receiving a blood transfusion from an unknown donor? Well, my opinion is that it is in there and it does affect you. We did breach this question a while back. After the vaccines came out, people were requesting non-vaccinated blood. There was some blood banks that did separate that out with questionnaires from the patient. They were testing the blood. They were asking the patients questions, were you vaccinated? And that blood did get separated out. I don't know, if every blood bank has that availability. Obviously it doesn't, because you just experienced that. I don't know that even the blood banks that did have that separation out and had that availability still have that availability. Maybe if you were in the 1% elite, you could get anything you wanted. I just saw that the 1% elite that were traveling to Davos to the World Economic Forum's climate change summit that's coming up are all requesting, demanding non-vaccinated pilots to fly their private jets. They won't fly with vaccinated pilots. So I don't want to offend anybody that's listening to this that did get the COVID vaccine. But if you listened to me long enough, I think that was a grave mistake. There's very big dangers in that COVID vaccine. There's dangers in any vaccine. And this one is the worst, followed closely by a few others. But this is a horrible vaccine. It's not even a vaccine. It is a DNA danger tool is what it is. And it is, it's you are exposed to, even if you never got the vaccine, you still probably, if testing was available to know if there's mRNA or this DNA fragments from the vaccine in your blood, I'd probably test positive for it. You would too, even if you didn't get a transfusion and didn't get the vaccine, because there's so much cross-contamination and because there's so much of contamination through anybody that you come in contact with. So I'm not sure that we're not all contaminated. But then you have to weigh out the pros and cons of, okay, do I not get a blood transfusion, which could save my life and really help me get over this giant hump that I'm dealing with so that I can continue on with other treatment? If I was in your situation, I would probably get the blood. Like I've told you in the past, you'd have to put a gun to my head and I would still say no to the COVID vaccine. So it is a concern for those that are trying to be more diligent at and have both physiological reasons and moral reasons not to be exposed to this vaccine. But there's some things that are beyond our control, and there's nothing we can do. Last week, I submitted a question asking what you recommended to combat night sweats. Since the first night I started taking the adaptogen, because I suggested taking adaptogens. I went from changing clothing up to 4 times per night to not needing to change once, and a smaller amount of sweat around my neck and upper chest. Incredible improvement. I am beyond grateful. Thank you. Well, you're welcome, and you need to thank the Lord, because I didn't have the answer to that question before I answered it. And sometimes God just gives us wisdom, and so praise God. Give him all the glory. I have been getting a Lupron injection every 3 months, 7 months total so far, for metastatic prostate cancer, and my PSA levels has consistently registered less than 0.1. Recently, my oncologist has suggested, no, so let's back up this a little bit. I did not look this person up who did this, but if your PSA is less than 0.1, it's a good possibility they had their prostate removed. So when a person has prostate cancer and they're doing Lupron, if they still have a prostate, lots of times their PSA won't go this low. But if you don't have a prostate, it's your PSA should stay this low when you're doing Lupron. So Lupron is an androgen deprivation drug. So it just removes all your testosterone. That's what Lupron does. Okay, sorry. Continue. Recently, my oncologist has suggested I start taking this other drug orally 4 times a day together with a steroid, as this other drug can cause electrolytes to decrease if you don't take it with a steroid. I was told this combination of oral drugs together with Lupron injections can extend the time period that my PSA will stay at a low level. So understand, using an androgen deprivation therapy drug like Lupron, there's several others on the market, typically will work wonders to drop a person's PSA down in the tanks. But it typically, just historic use of it, will only keep PSA levels there from 2 to 5 years, and then all of a sudden they just start going up. And they don't know completely why, except I'll tell you in a second. Since taking this drug, plus prednisone, is a lifetime medication, what I'm told, someone has to begin this additional treatment. Wonder if there's other things I can do. Well, I did write a blog about this a couple of years ago, because this phenomenon of androgen deprivation therapy working for a period of time and then it stops working has been known for quite some time. And there's actually data and why they think it actually happens. It has to do with the receptors, the androgen receptors that it's working on. And this is the blog post that I wrote on it. So go to this blog post, because it's been proven that 2 different things, andrographis and EGCG, and I would add curcumin and resveratrol to this as well, work on that receptor to remove IL-6, interleukin-6 expression at that receptor, and will help a person be able to get the same benefits from androgen deprivation therapy for a longer period of time without having to take those other drugs. And it's pretty easy to get these nutrients. And in this blog post, I actually tell you exactly what to take to get this. So read that blog post, just search in the blogs, right there on the blogs, just search right there for prostate cancer, hormone health and regulation, and you see what I wrote about it a couple of years ago. I was reading this Mercola article on extensive. This section on anti-cancer benefits confused me. So she quotes this article. the person asking this question, exerts its anti-proliferative. So anti-proliferative means it's not causing proliferation of cells, meaning helping with cancer cells not proliferating, not growing, not replicating. And then this is the confusing point. Anti-apoptotic and anti-invasive influence via different molecules and pathways, including signal transducer and activator of transcription 3, nuclear factor kappa, light chain enhancer, and activated B cells. That's nuclear factor kappa beta or NF kappa beta. And peroxisome proliferation activated receptor gamma. That's called PPAR gamma. Hence, Xanthanthin shows great promise as a chemotherapeutic agent in cancer. Now, the confusing part is this right here, and this is the question. How is it anti-cancer if it's anti-apoptosis? Well, I did pull up that article, and you kind of have to read the article. So the article goes into explaining that actually Xanthanthin works on two different apoptotic channels. I think I've written some blog posts on what's called the intrinsic apoptotic pathway. That's the pathway that takes place inside the cell. If something is damaging the cell, it can fire this capsase pathway inside the cell and cause the cell to go through normal programmed cell death. And then there's an extrinsic apoptotic pathway that is stimulated by something outside the cell, attaching to different receptors on the cell membrane, stimulating the capsase pathway and causing the apoptosis to take place. Well, this actually takes place. A good part of the article is kind of arguing back and forth that there's evidence that apoptosis takes place at both those things, both through the intrinsic and the extrinsic pathway. But the key point was on this is the way they worded it. Understand sometimes writers of the studies aren't the best at English. Sometimes when you quote a study, sometimes you have to correct their English. It is anti-apoptosis. And later in the article, it says that it's anti-apoptotic to healthy cells, but it's pro-apoptotic, stimulating both the intrinsic and the extrinsic apoptotic pathway in cancer cells. So yes, a little bit confusing. You had to dig in and read the article a little bit deeper. Says the results obtained by Song, among others, show that the significant peak of hydrodiploid indicative of apoptosis. So apoptosis is when a cell goes through these what are called blebbies, where it starts to break apart. So apoptosis is normal programmed cell death. And not to get too deep into histology, but the cell starts to bleb or convolute in on itself and break apart. And actually, it's a recycling of cell material. So cell material, all the insides of the cell is filled with 1,000 mitochondria and ribosome and reticular activating organelles. All these different organelles, these giant. I think of inside of a cell, like inside of it's as busy as what's going on in New York City. You'd hate to have, all the benefits of what's going on in New York City be destroyed by a nuclear bomb. That's a different way a cell could die. A cell could die through necrosis, which is an unhealthy cell death. Like if you were poisoned, that's not normal programmed cell death. The cell just breaks apart and all the cell material spills out, and then your body has to deal with that material and detoxify it, and you can become sick from the cell death material itself, and you could develop, an immune reaction to that, and that's what's called a Herxheimer reaction, where the cell just kind of explodes, breaks apart, and you get sick. That's partly what happens when you do chemotherapy. It's causing necrosis, it's causing a pathological death of a cell. Where apoptosis is not a pathological death of the cell, it's a normal programmed death of the cell. So it goes through different phases of blebbing to actually recycle the material, and the hypodiploid phase of apoptosis is part of that blebbing. Sorry, you probably didn't want to know that. Detected by flow cytometry when the cells were treated with this, so they were purposely treated with an oxidative agent in order for this to take place, et cetera, et cetera. And it goes on here, it induces a capsase-mediated mitochondrial apoptosis. That's part of the intrinsic apoptotic pathway. And then later it says, it's regulated, and they gave descriptions in how that's actually happening in cancer cells. And this example was with lymphoma. So in cancer cells, it produces apoptosis. In healthy cells, it actually protects from apoptosis, early apoptosis. And it probably, if you read the whole article, you'd probably better read that it actually protects from the necrotic death of the cell. Would have been a better terminology, because Xanthizin actually acts as an antioxidant. And they have a whole section, I didn't copy and paste that, in this article about the antioxidant benefits of Xanthizin and how that protects against a cell poisoning, because that's what oxidation is. I recently got another breast thermogram done. It's my first since the full body was done at the clinic 2 years ago. The full thermogram 2 years ago did not show any activity in the breast. I was told that this was because frequently my type of cancer will not show up on a thermogram. Yes, that's true. This most recent thermogram, however, did show activity at the tumor site. Is this necessarily vascular activity that is feeding the cancer? Is it possible that it's inflammation related to topically applying frankincense and DMSO every day? So what will show up on a thermogram is metabolic activity. So metabolic activity can be cell growth and replication of cells. That's going to increase metabolic activity, and any increase in metabolic activity is going to increase heat. So what a thermogram is reading is heat. Now thermograms have negatives to them too. So some breast cancers don't, replicate quickly, therefore don't produce a lot of heat. Some cancers, breast cancer, are too deep to actually have the heat be expressed on the surface of the body, therefore you can't really see them on a thermogram. So it's not highly beneficial for a colon cancer or something. But increased vascularization could increase heat, so that's a possibility. But certainly doing anything topical on the skin is going to increase heat. So in this case, I would say, if you have been applying frankincense and DMSO on a daily basis, I'd say you got about a 99% chance that's what it's from. Now, if you really wanted to test it, you'd stop doing that for, a period of time. And it's an indeterminate period of time because you don't know how long that's going to take, but at least 2 weeks before doing it on a thermogram. But that would be one way to test it. Okay. I think that was the only, we do have our new video site up. It's not completely organized. Like I said before, we're still working on it, but you can go to our new video site. YouTube has been pulling videos off our site saying that it's misinformation. And my daughter, who works on our Instagram channel, is very frustrated because we have over 2,000 followers, which I know that's not that much, but we just started this. And she'll put up a video and we get 28 views. And she says, this is just impossible. We should have at least 2,000 views. Well, even our followers are not able to see our videos. So understand Instagram and Facebook and YouTube is shadow banning people like me, especially cancer related things, because it's called medical disinformation. And if you want to see our videos on Instagram, if you're an Instagram user, you have to go into your settings on Instagram and allow all videos, because it's with the new Instagram update, every Instagram user, that setting has been checked to filter out medical disinformation videos, which that's what we fall under. So, we've been producing a lot of stuff. We're getting shadow banned on Instagram, shadow banned on Facebook, shadow banned on YouTube. They're taking down our YouTube videos. Pretty soon our YouTube channel's probably going to be canceled. And we're getting shadow banned on Google. So that's just the way it is, folks. So if anybody does want to give us a testimony, we greatly appreciate it. We're trying to let people know who we are and what we do, and it's difficult to do that these days. Okay, questions. Which blood test shows how the immune system works? I find this test, an NK cell test, absolute lymphocyte test, CD3, CD16, CD56. Yeah, these are all tests that you could run to show the function of the immune system. Certainly, if you just want a general function of the immune system, you're running a simple CBC panel. So a simple CBC panel will show your total white blood cell count, and it will show your differentials. Now, it only shows the differential to lymphocytes, neutrophils, monocytes, basophils. It's not going to break the lymphocytes down into their particle cells. It's not going to show other immune modulator cells like all your CD cells. You have to get a more advanced panel for that. However, does a person need to get those advanced panels if they have a diagnosis of cancer? I do not think you need to get those advanced panels if you have a diagnosis of cancer. Those advanced panels are really for a diagnosis of an autoimmune disorder. So if you have an autoimmune disorder, if you think you have a genetic disorder in what's called your complement factors causing immune issues, then that can be a good test to get. Cyrex has what's called a lymphocyte map test, and that's probably your best breakdown of all your immune cells. Let me do a screenshot and show you what that looks like. That's what the Cyrex lymphocyte map attests for. That's probably your most your heftiest picture of testing for immune function would be that. That test is somewhere around $400 or something like that. But that's really, honestly, that would not necessarily be recommended for a cancer patient. It would be more recommended for somebody who has serious immune dysregulation, and that would be somebody with a serious autoimmune disorder. That's really what that would be recommended for. So if a person's got cancer issues and they're trying to get their immune system to function to help destroy the cancer, that's not really what this is a diagnostic tool to see what's wrong. It's not necessarily things that are correctable by using specific immune stimulation. This is telling us what's wrong because of something in immune dysregulation that's going on in the body, and because of an autoimmune issue. So I don't know that I would recommend that, but if you wanted, out of strict curiosity, to see all your total natural killer cell count and percentage, and all your cytotoxic natural killer cells and percentage of those, and total natural killer cells, your CD56, 16 T cells, all this fun guru stuff, you can certainly run that. And that's in the store. our lab store. I read that DHEA is an estrogen precursor, which made me think about my last Dutch test before cancer diagnosis. My results show that my estrogen was low, but my DHEA was very high for my age. Does it follow then that the DHEA was not turning into estrogen? Well, if I have a video on the Dutch test, I'm pretty sure. But let's look at um, what that would look like. I got an example of a Dutch test here. Oh, page 2. So here's what a Dutch test looks like. You're looking at all your hormones. Pregnenolone breaks down to progesterone. Pregnenolone breaks down to DHEA. DHEA is a hormone that's made in your adrenal gland. DHEAS is followed. That's different than DHEA. DHEA breaks down to DHEAS, then and testosterone, and then that can convert to these estrogens. So the most concerning estrogen is something that drives cancer is this 4-hydroxyesterone, this one right down here. This is one that can damage DNA. This is the one that most commonly attaches to the estrogen receptor on the cell membrane that can block apoptosis. Remember, I said that there's two different apoptotic pathways. What this is blocking is the extrinsic apoptotic pathway. So when you have estrogen receptor positive or HER2 positive cancer, it's this 4-hydroxyesterone that's attaching to that receptor on the cell membrane of the cancer cell. So it isn't the cause of cancer, it's just blocking apoptosis. Now, this can build up in the cell and damage the nucleus of the cell. So anything that builds up in the cell can be a cause of cancer. Now, you can't test for intracellular hormones. So that's not available, but what is being tested for is whether you have estrogen positive, estrogen receptor positive breast cancer. So it's being affected from the extrinsic apoptotic pathway. So the question is, can excess DHEA cause a buildup of these estrogens? But what you mentioned, without looking at your test, this is just an example test I just pulled off the internet. This isn't anybody's that I know. Is that you said your estrogens were low. These are the 3 main estrogens that are your main functional estrogens, and then they break down into the 16-hydroxy, 4-hydroxy, 2-hydroxy, and through methylation and the COMT gene break down to a methylated estrone. And then your body utilizes these and gets rid of these. But if these 3 were low and this was low, but your DHEA was high, could that have been a precursor to your cancer? And I'd say, no. I mean, I don't think so. I mean, if this was high, the DHEA is high, typically is a sign of that's part of your stress response. So again, I'll have a video on this for better understanding, but in general, your DHEA is excreted by your adrenals, and it's part of your stress response. So if a person is under acute stress or even chronic stress for a long time, they still could show elevated DHEA. Chronic stress over a greater amount of time, you end up with adrenal burnout, and then typically you're having low DHEA and low cortisol. But then that's what that first part of the first page, go back to it, of the it's right here. First page of the Dutch test also does a cortisol. You do a salivary cortisol test over time as well. You take 4 different samples. Now this person's is showing a depressed cortisol level. The red is the person's. This would be the high range. So if the person's that would be under an acute stress, they could be way up here in cortisol. Now they're showing a very low free cortisol, a very high metabolized cortisol. So they're metabolizing it, but very low free cortisol. They're in adrenal fatigue mode right here. Now this part here is probably somebody completely different. These are just two things I grabbed out. So this one would show that they're at a low level of DHEA. So maybe they're at a great adrenal fatigue, but they have pretty high levels of E2 and E1 at very, very high levels. So this is probably on the internet because it was used as an example of somebody that's in great danger of estrogen really affecting that person's cancer. So this is why a person would go on an aromatase inhibitor, would try to get rid of these estrogens. This would be a person that would probably benefit from an aromatase inhibitor. They got very damaging high levels of 4-hydroxyesterone. So they should be on at least natural aromatase inhibitors. But you know, every patient of ours that I've tested, these have been in perfect balance. Because they've been taking, you know, natural aromatase inhibitors. So they're not going to have the danger of attachment to that estrogen receptor. So your question, does it follow that then the DHEA was not turning into estrogen? Yeah, it does follow that it wasn't turning into estrogen. I would agree. Have you heard of high-dose melatonin instead of an aromatase inhibitor? I think that Nasha Winter's protocol. No, you could use high-dose melatonin too. That's, you know, I think I have a blog post about it. I would certainly write about that in my book, using anywhere between 60 to 200 milligrams of melatonin before bed. Now, normally, if you're trying to get to sleep, you take 3 milligrams of melatonin. So 60 to 200 milligrams is very high dose melatonin. It doesn't help you get to sleep any better, but it still will give you some of that advantage, but about the same advantage as 3 to 6 milligrams will. But it works on different systems, and it can help with different cancers, not just breast cancer, not just hormone-related cancer. Have you heard of bitter melon? Heard that they use it extensively in Vietnam for breast cancer. Yes, I have. I don't think I included that in my book. And I don't think I have written a blog post about that. But yes, I've heard of using bitter melon. It's actually I'm pretty sure it's in some supplements that we use. I could be wrong though. I'll have to look that up. But yeah, that's another nutrient that let me look it up. So I know bitter melon is an herb that is used for decreasing sugar. So it's in some of our supplements that we use to help people with diabetes. But we don't have it as a separate supplement. I think my cortisol was upside down, low when it should have been high, and vice versa. What does that mean? Well, it certainly means adrenal issues. So it can be because of stress issues. So remember, the adrenal glands, as well as the thyroid gland, secrete based upon nervous system input and other hormone input. So what hormones act on the adrenal glands? The pituitary. This is the nervous system that acts on the adrenal glands, the autonomic nervous system. So if you have perceived stress, meaning it might not even be any real stress, it's just perceived stress. It's called worry. It's another word for it. You will stimulate adrenal hormone output. So understand, Stress hormones have a distinct purpose, a good purpose, a positive purpose. Um, you know, uh, you know, if you're walking down the street and somebody comes at you with a knife, you want to have a healthy adrenal gland to stimulate stress hormones so you can, you know, beat the daylights out of that guy or run away as fast as you can. That's going to be a sympathetic stimulation. Your sympathetic nervous system is going to be stimulated. Your parasympathetic is going to be downregulated, and you're going to be able to flight, flee or freeze or get out of that situation and protect yourself. But when we have, nobody chasing us and nobody, trying to kill us, but we perceive that like health issues or relationship issues, or we just tend to be high anxiety person. So we tend to just, ruminate on these things. Then we're stimulating our adrenals and we're just causing just a lot of adrenal dysfunction. You can get these upside down curves. Now, another issue in a person that has the tendency, let's say they go, well, that's me. I tend to worry about things and I tend to just overthink things and I'm just constantly just it's rolling around in my head all the time. And you also have to look at glutamate levels. Um, and so glutamate is different than glutamine. Glutamate is a neurotransmitter that's an excitatory neurotransmitter. And I'm pretty sure I have several blog posts and videos on this because it does tie to multiple genetic factors. You can have some genetic issues on your GSH genes and your GAD genes that if you have defects on those, you convert glutamine in your diet, which is amino acid from, eating foods that have protein. You convert it to glutamine quite regularly, faster than other people do. And that's why some people tend to be just nervous Nellies. They tend to have more anxiety. They tend to, if they're medically oriented, they tend to be on anti-anxiety medication because they are obsessive compulsive individuals. Now, glutamine is a excitatory neurotransmitter that is not bad in itself. Matter of fact, people that they have discovered, people that have higher levels of glutamine are more intelligent. They study more. They don't sleep quite as much because they're thinking about things. They're inventors. They're creative people. So it's not a bad thing necessarily to have too much glutamine. But if you are then feeding that pathway excessively, which what is the worst form of glutamine on your brain is a thing called monosodium glutamate, right? And that is just a horrible form of glutamine that actually fires so strongly in the brain that it actually burns pathways out. High correlation between obsessive compulsive disorder people and glutamate levels in the brain. So that's where that, nothing will clear that out perfectly, but trying to really limit any foods that have MSG is really, really important for those people. Even things with additives, colorings and things can stimulate glutamate um, quite strongly. Sometimes people think it's a dopamine issue, but it's really a glutamate issue, really a big problem. And then glutamine, excitatory neurotransmitter, fires the sympathetics, fires the pituitary, fires the adrenal, and it's this whole negative cycle. That's why I talked about it with cortisol, because it's just a huge negative cycle and it can burn out. You really need to get a hold of it, from a spiritual standpoint too. Do different mental practices where you're just going to resort. Prayer and meditation can be extremely helpful. Getting outside and grounding yourself can be extremely helpful too. Adaptogens would be the first go-to as far as nutrition goes. Please remind me how many days one should wait after chemo before doing a cheek swab. Um, I just I'd give it at least 48 hours. You don't need to really wait longer than that. Give it 48 hours, I would say. Any other questions? Well, I hope all of you have a wonderful Christmas planned with your family and that you could just relax and enjoy family. We are not closed next week. We're closed on Monday and we're closed on Monday the 1st. So Angie will be gone all next week, but otherwise everybody else will be there. I think I'll be there. Merry Christmas. Have a blessed time. Remember what the season is for. And I just wish you guys all the best. All right. Love you all. Bye-bye.